If our clients want to automate their quality measurement process, do they need to be using the Fast Healthcare Interoperability Resources Standard, also known as FHIR, which we spell FHIR?
I think we should all be advocating for the FHIR standard, but it has less immediate impact on your choices and your function than you might think. FHIR, that is the Fast Healthcare Interoperability Resources Standard. FHIR is a means to an end. You should invest most of your time, money, and energy in getting to that end. That end is high value, highly reliable, highly effective healthcare. FHIR is just one credible path and one step in that credible path to that universally desirable end. You should advocate for FHIR politically. You should pressure your vendors to provide it by asking them how much they support it. But I don't think you should include it today in your buying decision. You need to measure the quality of your care today. It can make a big difference in your payments from insurers, particularly for Medicare. Your quality scores are increasingly visible to your patients and affecting their provider choices. And you need ultimately to grow your measurement system into a scalable and sustainable measurement system to help carry you into our high value healthcare future. Buying FHIR today is a bit like being the first in your community to own a fax machine. Who can fax to you? Who can you send faxes to? There's no problem really with the FHIR standard. It's a good standard. It's usable. It's better than most, maybe all, alternatives. More vendors are capable of it than actually use it. As it gets into broader use, we'll find holes and weaknesses in it. And once found, we'll fix those problems and eventually evolve the standard into something better, and perhaps even with a new name. It will not be FHIR as we know it today that you will integrate into your future systems. It may not be called the Fast Healthcare Interoperability Resources Standard. It will evolve just as the HL7 clinical data architecture was the basis of and evolved into FHIR. Now, we at Mingle Health can read and incorporate your FHIR source data into your quality assessments. The three big problems we face today with the FHIR standard: one, it's not in universal use. We can't get it from everyone. Two, when used, the data is not universally populated with accurate, usable data. The biggest problem is that documentation still relies far too heavily on free text without enough structured documentation in your medical record to populate a FHIR message. Until all of your healthcare data is machine usable, FHIR really can't take hold. If your data is structured, our job becomes easier and we can provide more and better data for you to improve and prosper. And it makes a bigger difference to us and then ultimately to you to migrate off text towards structured data than it does to migrate to any specific standard, be it HL7 CDA or FHIR, QRDA, RX norm, SNOMED, LOINC, CBT, ICD. We can really move data around between those standards fairly easily compared to our ability to read your intent from a unstructured textual entry. There is a bigger difference in function and utility moving from that unstructured textual entry to any structure than it is migrating between structures. The biggest barrier between the current state and adoption of the FHIR standard is the lack of structured data documenting the patient's typical annual healthcare experience. Let me go a step further. FHIR is an intermediate outcome. You're becoming more familiar with the term intermediate outcome as we talk about quality measurement. But in that measurement system, I think it's just as valid a concept. FHIR is intermediate. It's not the desirable end in itself. It is one of many potential intermediate goals to get to a fully digital system. And even a fully digital system is intermediate. It's not what we want. What we want is the end result of that fully digital system, that overarching goal of high value, highly reliable, highly effective healthcare.